السلام عليكم. I'm Dr. Tariq Al-Zayyad, Professor of Urology. We will talk today about the topic of urologic trauma. It's a part of the general trauma, but it constitutes a moderate item in the trauma generally. The location of the genitourinary trauma, the kidney is the most affected organ of the genitourinary system in 67% of the urologic trauma, followed by the bladder in 22%, then the external genitalia and the urethra, and the least organ in the urology affected by trauma is the ureter. And we will see why this distribution. If we speak about the renal trauma, we will say that it constitutes about 1 to 5% of all traumas and about 10% of the abdominal trauma. It occurs more in male, the mean age from 20 to 35, which are more prone to this trauma. Isolated renal traumas are not common. Coexisting injuries are identified in 14 to 34% in cases of blunt trauma, while coexisting injuries are present in 50 to 80% of penetrating trauma cases. What is the mechanism of trauma for the kidneys? Any trauma could be either blunt, penetrating, or iatrogenic. The blunt trauma is the most common in renal trauma, constituting about 90 to 95% of all the renal tumors. In blunt trauma, this occurs as in traffic accidents and sports and falls from heights. All these constitutes the blunt trauma. The penetrating trauma, as usual, either the stab wounds or the gunshot. On the other hand, the iatrogenic trauma is a complication of surgery, as in cases of extracorporeal shockwave lithotripsy. When we do renal biopsy for the patient, this is trauma. In endourologic or percutaneous procedures for stone surgery, this is a kind of trauma for the renal parenchyma. Renal injuries could be divided according to the severity into 5 grades. The first grade in this figure, you can see here, it is only a limited subcapsular hematoma. The parenchyma is totally intact. There is no injury in the parenchyma. In grade 2 trauma, you have a small, less than 1 centimeter cortical injury with a contained non-expanding hematoma. In grade 3, it is also a cortical laceration, more than 1 centimeter, not reaching the pelvic calyceal system. There is no extravasation, and still the hematoma is contained, not expanding. Grade 4 trauma, you have multiple lacerations, corticomedullary, long laceration reaching the pelvic calyceal system. There is urinary extravasation, and there may be segmental vessel injury. The most severe type of trauma is grade 5, where you have a shattered kidney. Shattered kidney, you have all the kidney is lacerated. You may find one pole of the kidney shattered away from it, or renal pedicle avulsion or injury, the main renal pedicle, not the segmental as in stage 4. The most renal injuries are minor. Thank God, most renal injuries are minor. Significant renal injuries, including lacerations and vascular injuries, account for 27 to 68% of the patients with the penetrating trauma. While in the blunt trauma, the major injuries constitute only from 4 to 25%. The pedicle injuries are frequently caused by the deceleration. You know what's the deceleration injuries? Anybody can say what are the deceleration injuries. Yes, the injury is caused by the momentum of the body. These are the most common trauma that cause the pedicle injuries. Grade 1 and 2 injuries, they heal completely, whereas the higher grades result in permanent parenchymal scarring. When you are confronted with a patient in the ER with suspected renal trauma, what you will do for him? As any trauma or shocked patient, you will secure the airway, control any external bleeding if it is stab wound, and you will do resuscitation of the shock. These are the general management of any trauma patient. Then you will make physical examination is carried out during stabilization in order to have your focus where is the site of the trauma. When you see a patient with road traffic accident, for example, and having this picture, first of all, you will have the patient mostly will have hematuria. Flank pain, if he is conscious, he will complain of flank pain. Flank ecchymosis, like you can see here, this is the flank, the area of the kidney, and there is ecchymosis on it. Flank abrasions or wounds, fractured ribs. If you have any sign of fractured rib, whether right or left, it will direct your attention that the underlying kidney may be injured, as the kidney is protected by the lower thoracic cage and the lower ribs. You may have abdominal distension if there is perinephric hematoma. You may have abdominal mass and abdominal tenderness. All these should be excluded or confirmed during the physical examination. What about the hematuria? Of course, it is the best indicator for the traumatic urinary injury, but it may be absent in some cases. It is only present in 80 to 94% of renal traumas. Keep in mind that the degree of hematuria and the severity of the injury do not correlate consistently. That means that the injury may be severe and there is no hematuria. As in these cases, where the hematuria may be absent in 15 to 20% of renal vascular injuries, which is one of the major renal injuries, or grade 5, you may have a renal vascular injury, you may have avulsion of the uretropelvic junction, or in penetrating traumas where the trauma is directed to the parenchyma, not reaching the pelvic LCL system. So there will be no hematuria in these cases. But still, it is a severe form of renal injury. In the lab, what will be done in the lab is not usually helpful for a patient with renal injury. The urine you will see in the urine examination, you will see just hematuria, either grossly or by the dipstick. Most preferably, we will use the first catch of urine, because the later samples will be often diluted by the diuresis as you are resuscitating the patient. Serial hematocrit measurement indicates blood loss, whether it is renal or any other associated injury. Also, you will have to be sure that what about his kidney function and the creatinine, whether it is normal or abnormal. What about the trauma in a pediatric patient? The children are at greater risk of the renal trauma. Why? Because, of course, one of the stability and one of the causes that leads to preservation of the kidney during trauma is the perinephric fat, the strength of the lower ribs, and all these are deficient in the pediatric population. So the trauma to the lower ribs in the children will cause more renal injuries than the adults. Also, children have some peculiar things, as they have a high catecholamine output after the trauma. When the catecholamines are at high levels, the child will not be shocked, because this will maintain the blood pressure until approximately 50% of the blood volume has been lost. Yani the child will bleed half of his blood volume before the signs of shock will appear on him. Therefore, in the pediatric population, do not depend on the shock in order to determine if you have to manage this patient after trauma or not. Also, in the children population, any microscopic hematuria, you should resort to imaging studies at once in order to exclude renal trauma. Don't wait for gross hematuria. What are the indications of imaging generally in the renal injury patient? Any patient with penetrating trauma or having gross hematuria or microscopic hematuria and the systolic blood pressure is less than 90 millimeter in mercury, this is in adults. As we said, the pediatric patient, if he has microscopic hematuria more than 50 RBCs per high power field, or according to the mechanism of injury, if there is flank impact as you saw in the picture, or if it is a deceleration injury as falling from a great height. In all these conditions, you will resort to imaging study to diagnose the site and the degree of the injury. Now, what are the imaging tools that we have? The preferred imaging study is the contrast-enhanced computed tomography, or CT. The CT provides both anatomical and functional information about the involved kidney. What we will find on the CT study that suggests that we have major injury. This is a CT. The right kidney here, there is a medial hematoma. This is the kidney, and this is the hematoma outside the kidney. This is the left normal kidney. So a medial hematoma, this will suspect that there is renal pedicle injury. Also, we may find medial extravasation. This is urinary extravasation, which will suspect uretropelvic junction disruption or injury to the pelvic calyceal system. Or otherwise, you find here a white left kidney, which is normal because it is enhanced by the contrast. On the other side, the right side, there is no enhancement by the contrast, and this means that the renal artery has been injured. There is no blood supply to the kidney. These are the findings that suggest renal injury in the CT study. What about the gold standard intravenous pyelography or intravenous urography? It has been replaced by the CT. As we said, because the intravenous urography will show the functional element only, but the CT will show both the functional and the anatomical. Besides, the CT will diagnose also if there is any associated abdominal injury other than the kidneys, while the urography will show only the urologic system. So when we resort to the intravenous urography, if the patient is unstable and we are going to the OR and there is no available CT, or if the condition doesn't permit that we will transfer the patient to the CT department. So we will do it intraoperatively. We have inside the OR the fluoroscope, and we will inject single shot intraoperative IVP. Only a single film is taken 10 minutes after intravenous injection of the contrast medium. This will declare if the kidneys are functioning or not, if there is any extravasation. So we will, by this film, we will decide if the kidney is injured, we will open. If the kidney is intact, we will not open. And in a study, they found that the film quality was adequate to avoid renal exploration in 32% of cases of trauma in the OR, and the IVP, the rapid sequence or the single shot intravenous pyelography prevented exploration due to normal kidneys in trauma patient in about 32% of these patients. Other invasive imaging study, but it is resorted to in special cases, is the arteriography, where it is used to define arterial injuries or to localize arterial bleeding for embolization. You know, in some situations, you may resort to interventional radiology department in order to solve the problem of the hematuria or of the renal injury when you suspect minute renal injury trauma or traumatic arteriovenous fistula. So arteriography, you can see the bleeding vessel, you can see the site of the fistula, and just the interventional radiologist will do embolization of this small vessel and the problem will be solved. The ultrasound have a minor role in the trauma patient, but it is the study available in all hospitals and clinics. So as a primary, as we say, it is a primary investigational study. It is available, it is used in the initial evaluation and can define the retroperitoneal hematoma only, but it will not decide the site of the trauma, the severity of the trauma, if there is any other organs traumatized or not. So as we say, the contrast enhanced CT is the study of choice in the trauma patient. How you will deal with a patient with renal trauma? Non-operative management is the treatment of choice for the majority of the renal injuries. As we said that the renal injuries, most of them are minor, so a conservative or the non-operative management is the treatment of choice. The overall exploration rate for blunt trauma is less than 10%. Yani all the blunt trauma for the kidneys, only 10% of them will need surgical exploration. If you will do surgical exploration, take care that in a traumatized patient, if he is shocked and you are going to decide to explore, there is a possibility of nephrectomy in order to save the life of this patient in not less than 13 to 20% of cases. The conservative management constitute 90% of the renal injuries. You will admit the patient to the hospital, bed rest and required hydration and antibiotics, continuous monitoring of the vital signs until the hematuria disappears. What are the indications for surgical management in a patient with suspected renal trauma or diagnosed even renal trauma? If the patient is hemodynamically unstable, because you are transferring blood, you are transferring plasma, you are putting fluids, crystalloids and everything, and his vital signs are going down. This means that the hematoma is expanding. It is not confined within the renal capsule. So if you wait more than that, you will lose your patient. or if there is exploration for associated injuries. If you have also bowel injury, liver injury, splenic injury, all these necessitate that exploration will be done for both the renal and the associated traumas. If it is expanding or pulsatile perirenal hematoma, in grade 4 and 5 injuries where there is vascular injury, if there is incidental finding of pre-existing renal pathology, this means that you have a renal trauma in a kidney with, we can say, pelviureteric junction obstruction. The patient is known to have pelviureteric junction obstruction and he didn't show for management before, and it is diagnosed during the entity of the trauma, so you will explore for both. You will repair the obstruction and at the same time you will manage the injury. Also, if you tried at first radiologic embolization of the vascular injury and it didn't work, so you will resort for exploration. So in these situations, the surgical exploration for the kidney will be done. As we said, the possibility of nephrectomy is high if you explore it in order to save the life of the patient. So the ability to reconstruct an injured kidney depends on numerous factors. If the patient is unstable with low body temperature and poor coagulation, he cannot risk an attempt to repair if a normal contralateral kidney is present. You should be aware that the contralateral kidney from the CT or from the IVP, the rapid sequence that we have done, the other kidney is normal and you explored and the patient is unstable, so you will nephrectomize the affected kidney. Extensive renal injuries when the patient's life would be threatened by attempted renal repair. As we said, if you have a shattered kidney or if you have a renal pedicle avulsion, which is grade 5 trauma, in these cases you will not consume the time in trying to repair a shattered kidney, getting a piece from here and here and trying to suture them together, and the patient is going down vitally. No, in these cases you will do nephrectomy and he is having a well-functioning other kidney. The post-operative management and follow-up. Any patient managed for renal trauma, you will repeat the imaging for the hospitalized patients within 2 to 4 days. And the patient is hospitalized, you diagnosed him by CT. After 2 to 4 days, when you are going conservatively, you will do another CT to see the degree, if it is increasing, if it is stable. Also nuclear scintigraphy before discharge, the isotope scan, in order to document the functional recovery of the patient. After 3 months from the major renal trauma, the follow-up should involve physical examination, urine analysis, individualized radiologic investigation. This means you may, in some patients, you will only say, I will follow him by ultrasound because the discharge CT was good, so I just want to see by ultrasound if there is any change. Other patients you will do IVP, other patients you will do CT, enhanced contrast, according to every individual patient. Also, the serial blood pressure measurement. Why? Because the renal trauma in general may be a cause of new developed hypertension. As we know, the renal parenchymal injury and scarring will stimulate the renin-angiotensin system, and this will lead to renovascular hypertension. So a patient with history of renal trauma should be followed for his blood pressure in order to diagnose any recent hypertension. Of course, it goes without saying that we will follow up his serum kidney function. Secondly, we will move to the urethral injuries. As we said, it is the least organ affected by trauma in the urogenital system. Traumatic urethral injuries are uncommon because the ureter, it is a well-protected retroperitoneal structure with a narrow diameter, accounting for only 1% of all genitourinary injuries. Iatrogenic urethral injuries are the most common. Iatrogenic means it is surgically induced. They may occur during colorectal surgeries, endourologic and gynecologic procedures. During our endourology management for stones or for strictures, we use semi-rigid ureteroscopes. We use some instruments in order to disintegrate the stones, lasers. All these are possible causes for urethral injuries with different degrees. The delay in the diagnosis is the most important contributory factor in morbidity. The kidney, if it is traumatized, there will be pain, there will be hemorrhage, there will be hematuria. It is apparent. Also, the bladder and the urethra, if they are injured, they are apparent. What is the problem in the urethral injury is that most probably the injury is delayed after 1 or 2 weeks, even maybe 1 month after the surgery, even in the colorectal surgery or the gynecologic procedures. Sometimes the patient is not diagnosed as having a urethral trauma except after a lapse of some time, and this is the problem that will add to the morbidity of this patient. Also, the CT is the radiologic study of choice in urethral injuries. The intravenous urogram was the standard and it is replaced by the CT. But if the results of the IVU or the intravenous urography and the CT are inconclusive, the next step would be an invasive diagnostic procedure. You will do a cystoscopy for the patient, you will put a ureteric catheter in the ureteric orifice and inject the contrast material in order to see if there is any urethral trauma or urethral extravasation. This is an excretory urography or intravenous urography. It demonstrates extravasation of the dye in the upper third of the right ureter. These are the kidneys. The left ureter is intact, reaching to the bladder. The right ureter is intact up to the upper third, where extravasation of the dye, and there is no contrast behind this. This means that complete urethral transection has been done at this level. The operative decisions in the presence of urethral injury are based on several factors. First, whether the tear in the ureter is partial or complete. Just a part of the circumference of the ureter may be injured, or it may be taken in a stitch, only partial circumference, or the whole ureter may be transected or ligated by a suture during difficult surgeries. Also, which segment of the ureter is involved, the upper segment, the middle third of the ureter, or the lower segment. All these will affect the decision of repair of the ureter. Also, the viability of the ureter and the surrounding tissues. If there is any associated urological and non-urological injuries, and the general condition of the patient. All these factors should be put in mind when you are taking a decision how to manage the urethral injury present. Urethral injuries with delayed diagnosis or in an unstable patient are initially best managed, as we said before. Most of the urethral injuries are diagnosed late, after you finish your urologic surgery or the gynecologic or the colorectal surgeries. 1, 2, 3 days, 1 week, and the patient starts to say loin pain. If he has a single kidney, you will find that there is oliguria up to anuria, so you start to investigate. If this is the case, the best is to put a percutaneous nephrostomy in the affected, in the kidney of the affected ureter to drain the kidney, or a urethral stent by double J or single J stent. Of course, the nephrostomy placement is more easily and it is more safe for the patient. It doesn't need anesthesia. It is done in ultrasound guided in the radiology department. On the other hand, the urethral stenting should only be used for selected patients with minor urethral injuries or injuries after ureterorenoscopy. You know, during the endourology, we can see the lumen of the ureter by the telescope. So if we are suspecting that there is perforation of the ureter or any injury, we can inject contrast material. If we found that there is extravasation from that injury, on the spot we can apply a double J stent in this ureter. Otherwise, in other cases, a nephrostomy is better to be applied. If you have the traumatized edges of the ureter like this, they are not surgically clean ends, so the management, as in any case, you will do debridement of this affected ends. You will do spatulation. Spatulation means that you take it obliquely like that in order that primary anastomosis will have a wide anastomosis, and you will suture both ends together. This is in the small cut ends of the ureter. If there is a gap in the ureter and you couldn't approximate them together, many procedures can be done. You can take flaps from the ileum to replace the ureter. The whole ureter can be replaced by a segment of the ileum. If we shift to the bladder injuries, as we said, the bladder is the second most common genitourinary injury after renal trauma. It constitutes about 22% of the genitourinary traumas, but 5 to 10% of all patients with trauma. 30% of patients with pelvic fracture disease have bladder rupture. Any patient with pelvic fracture, 30% of them will have associated rupture of the bladder. On the other hand, 70 to 95% of the bladder injuries will have pelvic fracture. The urinary bladder, the empty urinary bladder, is generally protected from the external trauma because of its deep location inside the pelvis, in the bony pelvis. But the full bladder is not the same, because the full bladder is a pelvic-abdominal organ, not an absolute pelvic organ. The etiology of the injuries, as we said, either blunt, penetrating, or iatrogenic. The blunt trauma, like we said, the pelvic fracture, it is the commonest cause by blunt trauma to the abdomen, like a kick to the abdomen with a patient, in a patient with a full bladder. This may cause ruptured bladder. Penetrating trauma to the abdomen, nearly half of all bladder injuries are iatrogenic. The most common field of surgery that send to us requests for managing bladder injury are our friends, the obstetrics and gynecologists, because they work in very deep situations. They have multiple recurrent cesarean sections in their patients, or the deep pelvic tumors. So very frequently there is requests for bladder injury or urethral injury during their surgeries. The most common etiology of bladder injury during open surgery, as we said, the obstetric and gynecology. The degrees of bladder injuries, it could be just a contusion in the bladder wall with no extravasation of urine, or it may be extraperitoneal rupture of the bladder at the lateral wall or the floor of the bladder, and the extravasation of urine here will be into the pelvis and the retroperitoneum. Or it may be intraperitoneal rupture at the dome of the bladder and the extravasation of urine into the peritoneal cavity between the intestinal loops. The two most common signs and symptoms of major bladder injuries are: number one, gross hematuria in 82% of cases, and abdominal tenderness from the extravasation of urine in 62% of cases. Bladder rupture does not occur as an isolated event in normal individuals. Most conscious patients have pronounced non-specific symptoms such as either suprapubic or abdominal pain and or the inability to void. How to diagnose a patient with suspected ruptured bladder? You have the what we said, the retrograde or the ascending cystogram. You put a small catheter in the urethra and inject contrast material up to 300 or 400 milliliter, and you will, under fluoroscopy, you will see the contour of the bladder. Is it normal, or if there is extravasation, and where is the extravasation, if it is extraperitoneal or intraperitoneal. Depending on the facial integrity in the patient, the contrast material may extend into the retroperitoneum, the scrotum, the phallus, the thigh, and the anterior abdominal wall. This is in the extraperitoneal rupture of the bladder, while the intraperitoneal extravasation is identified by contrast material that outlines the loops of the bowel. This is the flame-shaped contrast during ascending cystogram or retrograde cystogram, and this is diagnostic of extraperitoneal rupture of the bladder. Just a catheter for 2 weeks was inserted in his bladder, and this was his normal bladder again regained. Also, in diagnosis of bladder injuries, the CT plays a role. So instead of the plain film ascending cystogram, we can resort to the CT cystography. It is now frequently selected as a more efficient means than plain films cystography to assess the bladder. As we said before, the CT have the advantage of diagnosing any associated injuries rather than the urologic organs. This is a film, a CT cystogram, demonstrating extravasation of the dye between the loops of the intestine, here and here. These are the loops of the intestine, and the dye is extravasated between them. That demonstrates the intraperitoneal rupture of the bladder. How to manage a patient with bladder injury? If it is a blunt trauma and the rupture is extraperitoneally, and it is uncomplicated, so the management is conservative. Just insertion of a wide bore or a large bore Foley catheter, and after 2 weeks cystography will be done. If the bladder is intact, you will remove the catheter and the problem ended. And of course, you should cover the patient with prophylactic antibiotics. On the other hand, if the blunt trauma with extraperitoneal patient is having infected urine, or he has a pelvic abscess, or there is any fistula from the trauma, so surgical exploration. Don't resort in this case to just putting a catheter, because complications will occur after that. So if it is uncomplicated, you will put a catheter. If there is complication, you will explore the patient. Also, if a stable patient is doing exploratory laparotomy for associated injuries, as bowel injury with the blunt trauma, and it is extraperitoneal, so the urology will attend the operation. The general surgeon will deal with the colonic injury or whatsoever, and the urologist will repair the extraperitoneal rupture of the bladder in this case. Any intraperitoneal rupture of the bladder should be explored. Why? In order to avoid the development of peritonitis, as it carries a high mortality rate of 20 to 40% due to the associated injuries. Lacerations are usually large with potential risk of peritonitis. The fourth item in our topic today is the urethral trauma. As we know, the male urethra, or the urethra in general, but we are talking here about the male urethra, is divided into either posterior urethra or anterior urethra. The posterior urethra constitutes the prostatic urethra, اللي هي running inside the prostate gland, and the membranous urethra that is surrounded by the external urinary sphincter. The anterior urethra, on the other hand, constitutes the bulbar urethra. This is the bulb. Here is the bulbar urethra and the penile urethra. So these are the four parts of the male urethra. Anterior urethral injury usually is affected by blunt trauma, and the most common is the straddle type injury. When you are falling astride, you know when somebody is falling on a fence, بيركبوا زي الحصان كده بالظبط، تمام؟ This is the falling astride. This is called the straddle injury, and here the urethra is crushed against the inferior border of the pubic bones. Posterior urethral injury, usually blunt trauma, is by pelvic fracture disease. It is the main cause, and it usually leads to urethral distraction. Distraction means that both ends of the urethra are totally distracted from each other. There is separation between the proximal and the distal segments of the urethra. Or it may be iatrogenic injury during application of urinary catheters or endoscopies during surgery. May lead to iatrogenic urethral injury. They constitute about 3 to 5% of the genitourinary trauma. 10% of males and up to 6% of females sustaining pelvic fracture will have urethral injuries. Girls younger than 17 years are more prone than women, most probably due to the greater compressibility of the pelvis in the young ladies. How to diagnose a patient with urethral injury? The clinical signs of anterior urethral injuries include blood at the meatus, and this is the crucial point in a patient suspected for urethral injury. Any trauma patient having a blood, even if it is a spot of blood at the meatus, so this is highly suspicious of association of urethral injury. Of course, there will be perineal hematoma, gross hematuria in some cases, and urinary retention in other cases where there is separation or distraction of the urethra. Urethroplasty should be performed in any case of suspected urethral injury. In severe trauma, the buccal fascia surrounding the corpora may be disrupted, resulting in blood and urinary extravasation into the scrotum. This is a urethrogram showing normal urethra with the contrast passing through all parts of the urethra, and there is no strictures or extravasation. This ascending urethrogram, you can see also the urethra there is no extravasation and the dye is running, but you can see that the caliber here, there is a difference in the caliber between the anterior urethra and this is the posterior urethra. This is most probably in a trauma patient. Of course, this is grade 1 urethral trauma patient having a perineal hematoma. The hematoma is compressing the urethra from outside, but the urethra itself is intact. And this patient is the minor form of urethral injury. He needs nothing rather than a catheter for 1 week until the hematoma is absorbed, and you will remove the catheter and the patient will pass urine freely. This is a grade 2 urethral disruption. There is extravasation of the contrast material here at this segment from the posterior urethra superior to an intact urogenital diaphragm. We will compare it from this picture, which is grade 3 urethral injury. There is extravasation of dye above and below with disrupted urogenital diaphragm. This is another retrograde uretherogram in a patient with a pelvic fracture disease, showing complete disruption here, complete disruption of the posterior urethra. And this is straddle injury, a patient with straddle injury where the bulbar urethra has been severed and the contrast material extravasating from it. The initial management for a patient with urethral trauma. Logically, and for all practitioners, a suprapubic cystostomy is the best way of treating this patient. Immediate suprapubic tube placement remains the standard of care. Why? Because if you try to vigorously pass a catheter or anything in the injured urethra, you may make a partial tear in the urethra into a complete tear. So the best thing and the safest thing is to do an immediate suprapubic cystostomy, whether by open procedure or now under ultrasound guidance. You can do it percutaneous technique, and just in the ER you can do it. Some surgeons, but these are urethral consultants, or they are all their life they have expended it in the urethral surgery. They do a primary realignment of the urethra. A single smooth attempt of passing a urethral catheter is reasonable if the patient is stable. If you are well trained for passing a catheter, that means that you are lubricating the urethra enough, you are working under complete sterile conditions, and you are smoothly passing a catheter. If it stops, you also should stop. Don't push the catheter more. Plus, this means that this patient will never pass a catheter, and you will resort to the suprapubic tube safely. Some patients make a railroad technique. This is during open surgery. Some patients pass a catheter from inside the bladder and pass it outside the urethra, then ligate another catheter in it from outside and pull it to get the urethra inside. The incomplete urethral tears are best treated by stenting with a urethral catheter, as we said, if the surgeon is trained for this. Why they insisted to realign the urethra or put a catheter or make the railroad or something like that? Because the studies have shown that if the urethra is at one line, even if you make a railroad and put a catheter, there will the stricture will develop at any time after you remove the catheter. But when you realign it, the stricture will be small, the fibrosis will be little, other than you leave two ends of the urethra severed like that away from each other. All this area will heal by fibrosis. So the fibrosis will be major, and during the surgery you will be in a problem to get the one of the ends, where is the other end. So why they insist for railroad and doing like that? These are the urethral surgeons, in order to put them at the same line, make the stricture less extent and the fibrosis to less extent. In posterior urethral disruption, the rupture defect between the two severed ends, what we said that it is a distraction injury and the severed ends are away from each other, this area fills with scar tissue resulting in complete lack of the urethral continuity. This separation is not a stricture. It is a true urethral rupture defect filled with fibrosis. So, in these cases, initial suprapubic cystostomy, 3 to 6 months later, definitive repair with urethroplasty will be performed. This is a combined cystogram. Combined means that you are injecting dye from the meatus and there is a suprapubic tube. You are injecting, here is the suprapubic tube, you are injecting contrast from here and here in order to visualize the bladder, the proximal urethra, and from here you are the distal urethra, and you can reach what the length of the segment that is strictured. There is complete posterior urethral disruption here, and this is the post-operative period after the cystogram after the urethroplasty was done. In contrast to posterior urethral distraction, the anterior urethral injuries are most often isolated. We said that the posterior urethral injuries often are associated with pelvic fracture. The anterior urethral injury, usually they are isolated injuries due to falling astride, kicks to the perineum, instrumental affection by urethral catheters or whatsoever. The majority of the anterior urethra occurs after straddle injury and involve the bulbar urethra, which is susceptible to compressive injury because of its fixed location beneath the pubis. As we said that there is compression against the pubic bones. Contusions and incomplete injuries can be treated with urethral catheter and follow-up ureterogram, as we saw in the ureterogram with a perineal hematoma, just compressing, and there is no contrast, a catheter for 2 weeks, everything will be okay. The second line of management, initial suprapubic cystostomy, is the treatment of choice for major straddle injuries involving the urethra. Open repair should be delayed at least several weeks after instrumentation to allow the urethra to heal and stabilize. All this is in the anterior urethral injuries. Anastomotic urethroplasty, as we saw the anastomosis of the ureter, the same principles apply for the urethra in direct end-to-end anastomosis of the urethra. We are left with the genital traumas. We have the trauma to the penis. Blunt phallic trauma injury is usually of concern only in an erect penis. That means that the flaccid penile injury will not result in penile fracture or injury to the penis. The penile fracture is the disruption of the tunica albuginea. You know the corpora cavernosa. There is 2 corpora cavernosa and 1 corpus spongiosum that includes the urethra. The corpora cavernosa are those concerned with the erection. So the penile fracture is the disruption of the tunica albuginea that covers both corpora cavernosa. Fracture typically occurs during vigorous sexual intercourse with masturbation, rolling over or falling on the erect penis. These are the usual complaints. A patient with penile fractures comes to the ER that during sexual intercourse he was changing some positions or something like that, and he heard a snap sound during the intercourse in his organ, and there is swelling of his penile shaft. These are the symptoms in the ER that the patient present with it. On the other hand, the penile fracture may be self-inflicted fracture. The erect penis is sometimes the adolescents they are the masturbators, they are playing, and they are trying to forcibly bend the erect penis in order to get it deflated or detumescent, so they cause rupture of the tunica albuginea and there is fracture of the penis. Other injuries like the gunshot, the stab wounds, machinery accidents, or animal attacks. Animal attacks, we have many patients coming with either, mainly they are dog bites in their penile shafts. Of course, you should have a good history taken from the patient. You will see the penile swelling and ecchymosis on the penile shaft, palpating the defect in the tunica albuginea. During examination, if you run your finger against the site of the trauma, you will find a defect in the tunica albuginea. A ureterogram is needed if there is associated suspected urethral injury. When do we have a suspicion of urethral injury? If there is a spot of blood at the meatus, this is suspecting a urethral injury. This is the usual picture that you see in the ER. We call it the eggplant deformity. Eggplant اللي هو الباذنجان الاسود، هي بتبقى زي الباذنجان بالظبط كده، تمام، من الهيماتوما. And here the large arrow indicates pronounced ecchymosis and swelling in this patient with a penile fracture sustained during intercourse. And here there is a blood at the meatus. This is during surgical exploration. They found a urethral injury, and here is the urethral catheter in place. The urethra should be debrided and anastomosis is done, and here there is a tear in the corpus cavernosum and it is sutured. The early presentation of the patient and the early management of this patient will preserve his erectile function. But the delayed or the neglected cases, fibrosis may happen, and if the patient even have erection, this fibrosis will lead to curvature of the penis and we will have a curved erected patient. So in the patients with penile fracture, rapid management should be done within 4 to 6 hours after the trauma. The last organ that we will talk about is the testis. The etiology of testicular trauma, either blunt injury. Blunt injury, usually the result of assault or sports-related events and motor vehicle accidents. It can result in the rupture also of the tunica albuginea covering the testes, contusion, hematoma, dislocation of the testis or torsion of the testis. The penetrating injuries due to firearms, explosion, and these are also weapon injuries resulting in the remainder of the cases. Whereas only 1.5% of the blunt testicular injury involves both gonads, about 30% of the penetrating scrotal trauma results in bilateral testicular injury. Most penetrating scrotal injuries, 72 to 83%, is associated with non-genitourinary injuries. Yani if there is firearm or stab wounds or something like that, it will not be isolated. In most cases, the injuries may include thigh trauma, penile trauma, perineal, urethral, or even the femoral vessel may be injured. To diagnose it, you should have a thorough history from the patient for the blunt scrotal trauma. Scrotal pain and nausea, because you know the testes are one of the trigger areas of the body, so any trauma to it the patient may suffer from nausea. Swelling and ecchymosis are variable, and the degree of hematoma doesn't correlate with the severity of the testicular injury. You may have a small hematoma and shattered testis. You may have a large hematoma and just a small tear in the tunica. so the degree of hematoma doesn't correlate. Scrotal hemorrhage and hematocele, along with tenderness to palpation, often limits the good examination of the scrotum. The patient will not be cooperative in order from the pain to let you examine him freely. Concomitant urethral injury should be suspected if there is blood at the meatus also. Penetrating injuries mandate careful examination of the surrounding structures, especially the femoral vessels, in order to don't lose the patient from bleeding. The ultrasound can be helpful to assess the integrity and the vascularity of the testis. It is rapid, readily available, and non-invasive. Because the ultrasound may be operator dependent, false positive and false negative studies range up to 94% of cases. There may be false positive or false negative. The ultrasound findings suggestive of testicular fracture include inhomogeneity of the testicular parenchyma texture and disruption of the tunica. A normal or equivocal ultrasound study should not delay surgical exploration. If you are suspecting any testicular injury, don't wait for more investigations. Exploration and saving the testis is better than delay for investigation and losing this testis. This is an ultrasound examination demonstrating hypoechoic areas. This is a hypoechoic areas, intratesticular, consistent with testicular rupture sustained by blunt trauma. Early exploration and repair of the testicular injury is associated with increased testis salvage, as we said, reduced convalescence and disability, and faster return to normal activities. Also, preservation of fertility and hormonal function. As we said, if you are suspecting, go ahead and explore this testis. You will not lose anything better than losing a testis. Minor scrotal injuries without testicular damage can be managed conservatively with ice, elevation of the scrotum, analgesics, and irrigation to clean the scrotum, and closure with stitches in some circumstances. On the other hand, penetrating scrotal injuries should be surgically explored to inspect for vascular and vasal injuries. This is a picture of testicular injury, rupture after blunt trauma. This part was shattered from the testis and it was removed, and here the testis is repaired, and we got a flap from the tunica albuginea and we covered the testis with it. Thank you. أي حد عنده أي استفسار؟ تفضل. ثلاثة لست شهور. ليه الانتظار؟ يعني احنا عملنا diversion of urine by supraurinary. تمام؟ بريس كل البوستيريور بريس يبقى معاها